Good evening. Let's allow a little bit of time for more members to join, then we will start. Thank you for those who've made time, who made it in time. We appreciate your punctuality. Let's give a couple of minutes for other colleagues, and then we can start. Thank you. All right. Good evening, colleagues, ladies and gentlemen. I would like to take this opportunity to welcome all of you to this evening's CME. We don't take it for granted that you have taken time to join us as we continue to educate each other and improve ourselves for the better care of our patients as we go along this career. This evening, we are going to have a discussion on the topic Beyond Atypical, where Amisulpride fits in modern schizophrenia care. I will be your moderator. My name is Rajab Saddam. I'm a consultant psychiatrist working at Kenyatta National Hospital and the current CME coordinator with Kenya Psychiatric Association. Our speaker today is a very seasoned senior consultant psychiatrist, Dr. Frederick Owiti, who has insisted that I only introduce him as a retired psychiatrist who has taught people beyond psychiatry. And he will be taking us through this presentation. In many cases, we usually find ourselves wishful thinking, where we say if we had a molecule, maybe the outcomes would be better. Amisulpride as a molecule has not been in our market for, I think, ages, and now we have an opportunity to hear its benefits and whether it's even available, or why are we even having this conversation at all. This CME is proudly sponsored by one of our partners from the pharmaceutical industry called Redefine Healthcare Limited, and we appreciate our partners for the sponsorship. We do encourage that you do have your questions in the Q&A, and we will get to them at the end of the discussion. But let the questions flow as the session continues. I take this opportunity to welcome our senior consultant, Dr. Awiti. Karibu sana. The floor is yours, Doc.
Thank you, Rajab. I also appreciate the Defined group who looked for me and asked me if I could do this. I welcome this because amisulpride is a drug that's not unknown to me. But I must say before I start that I don't work for the Defined Healthcare, and everything I say here will be things I know and nothing that I've been coerced to do for you all. So amisulpride has been in Kenya in different names. Names like Solian. The other one, initially I encountered amisulpride in the year 1999 when a student in medical school had the problem with the stelazine. And this stelazine made his neck go backwards. But then he came to me and I had still connection with somebody in London. And he went there and the guy gave him another formula of amisulpride. And the neck of this student returned to normal, but it didn't last long in medical school. I think he became overwhelmed by depression and other things and he went. Now recently, I also encountered a person with a similar problem treated in Madari Hospital. And one wondered what would happen. But when he came, I remembered amisulpride I gave him, and the neck returned and the body also returned. I don't know how it worked, like we used other products like piperidine or benzexol hydrochloride. This thing, the neck of this student returned back to its very normal side, and he has returned to Lusaka, where he was studying economics. So now I have great opportunity to present this product, which is now within us here, because there will be nothing like it is not available. It will be available. It is number second in the list of drugs that deal with psychiatry well. Number one is Leponex. The second one is this one. So the rest are also there. There are 5 that are known. So as I've said, amisulpride is antipsychotic and old but not very old. It's documented as effective, and that is correctly validated. The advantage that we have with this new one is that it has what absorbability. So it's not very difficult for patients that are difficult. Now, in the overview, we would say, what's going on? Yeah. What was happening?
We are already there. The setting is just changed over.
Yeah, sorry for that little brief interruption. Now, amisulpride is classified as a second generation or a typical antipsychotic belonging to the substituted benzamide class. And the key indications start now, primarily used for schizophrenia, both acute and chronic. It's effective against positive symptoms like hallucinations, delusions, and the rest. Effective against negative symptoms, social withdrawal, lack of emotion, lack of joining and entertainment. Other uses of amisulpride is post-operative nausea and vomiting at low intravenous doses. But what is amisulpride? It's a typical antipsychotic belonging to the substituted benzamide class. Primary indication is schizophrenia, acute or chronic. And unique features it has, it is one of the few antipsychotics with a truly dual mechanism of action based on dose. Security. Now, the mechanism of action, dopamine antagonism, selective binding, high affinity for dopamine D2 and D3 receptors. Limbic selectivity, higher affinity for the limbic systems than the striatum. This reduces the risk of movement disorders. In fact, that's why it worked here. And that is what happens at the synaptic cleft. You find the presynaptic neuron has got dopamine excessive release is released, and then D2 receptors and postsynaptic neuron goes down. Aberrant downstream signaling if everything is okay. And presynaptic neuron, this presynaptic neuron, you have the same activity and dopamine release and autoreceptor plus autoreceptor and can block and control. And that is very essential in controlling psychosis. And you find that D2 receptors and is effectively controlled. Dual action concept, low doses blocks presynaptic autoreceptors, increases dopamine release, which is essential for treatment of negative symptoms. High doses blocks postsynaptic receptors, which decreases dopamine activity and treats positive symptoms. Now, the receptor profile comparison, unlike other atypicals, for example, olanzapine, amisulpride has no affinity for D1, D4, and D5. It has no affinity for alpha adrenergic or histamine H1, and strong 5-HT antagonism linked to mood improvement. The other one, histamine 1, is also helps the people does not put weight gain. Weight gain is less, nothing. Pharmacokinetics or absorption, bioavailability 48%, Tmax bimodal peaks at 1 hour and 3 to 4 hours post-ingestion. But note that absorption is slightly decreased by high carb meals. Absorption, the bioavailability is approximately 48%, distribution, low protein binding 17%, metabolism, weakly metabolized. Hepatic insufficiency usually does not require dose reduction. Elimination primarily eliminated and changed in the urine, and half-life therefore is roughly 12 hours oral or 4 to 4 hours IV. Now, treating positive symptoms approach is targeted for rapid reduction of hallucinations, delusions, and thought disorders. Efficacy frequently compared to high potency agents like haloperidol, but with fewer side effects. Treating negative symptoms focus is here on apathy, social withdrawal, and blunted affect. Evidence utilized for predominantly negative schizophrenia, where the pharmacological agents often fail. Metabolic profile advantage, as I said earlier, H1, weight gain associated with significantly lower weight gain compared to medications like clozapine, olanzapine, and quetiapine. Glucose lipids generally considered to have neutral effect on blood, sugar, and cholesterol. Cardiovascular safety QT prolongation, warning that the potential it has got potentiality to prolong the QTC interval on ECG. Risk, Tosse de Pointes, rare but serious. Consideration, avoid concurrent use with other QT prolonging drugs like sotalol, erythromycin, and the one we use for antidepressants. Avoid drug interactions. Avoid levodopa. Amisulpride may block its effect. Avoid alcohol. It may bring increased sedation. Profile what's that? High safety profile with SSRIs and SNRIs, as it does not typically use the CYPD 450 liver pathway. That's what I was saying. Yeah, does not use so well. Maybe that's why it can be used high dose. Pregnancy and lactation. Pregnancy limited data generally avoided unless benefits outweigh risks. Lactation generally contraindicated due to potential transfer to breast milk. Patient monitoring checklists. 1. Baseline key ECG for QT interval. 2. Renal function, creatinine, EGFR. 3. Prolactin levels. 4. Weight, BMI, though risk is low. Risk on weight is low. Yeah, comparison with other atypicals, amisulpride versus risperidone, similar efficacy. Amisulpride often demonstrates better negative symptom control. Amisulpride versus quetiapine. Amisulpride is generally less sedating but has higher potential for prolactin elevation. Did you ask about it? Wait, yeah. Dosage and administration. Schizophrenia. Acute psychosis, use 400 milligrams to 800 milligrams per day, and the maximum dosage could be 1,200 milligrams per day. Negative symptoms, 50 milligrams to 300 milligrams per day. Renal impairment requires dosage reduction if CR creatinine is below 10 mils per minute. Formulations available as oral tablets, 50 milligrams, 100 milligrams, 200 milligrams, 400 milligrams, and intravenous solution for those people with post-operative PONV. And thank you, and nothing else.
Thank you. Thank you so much, Dr. Awiti, for that short but very elaborate presentation on amisulpride. For those of our colleagues who maybe have just joined us as we went on, today's discussion basically has been focusing on this molecule, amisulpride, that for a lot of us, especially the younger generation of psychiatrists, we may not really have interacted with it a lot. And this forum is basically want to give you maybe the confidence of what molecule is it and where and when do your patients benefit from it. Dr. Awiti has gone ahead to tell us it is indeed a second generation antipsychotic. It is used primarily in the treatment of schizophrenia, and the benefits are there both in the acute and the chronic phases. It does have benefits both in the positive and negative symptoms of schizophrenia, and also patients who suffer from post-operative nausea can benefit from it. It is one of the few antipsychotics that has the dual mechanism based on mode of action, where low doses are very effective for negative symptoms and high doses are very effective to tackle the positive symptoms of schizophrenia. Dr. Witty has gone ahead and told us about its mechanism of action, primarily targeting the dopamine 2 and dopamine 3 receptors, and also a high affinity for the limbic system, which is why it is one of the best to reduce or to avoid extrapyramidal side effects. It has no affinity for dopamine 1, 4, and 5 receptors or for serotonin receptors, and that is why it doesn't suffer the extrapyramidal side effects and also doesn't cause a lot of the metabolic syndromes we see with the others like the quetiapine and olanzapine. Apart from not having the issues of weight gain, it also has neutral effect on blood sugar and cholesterol. Another thing that we've talked about is drug-to-drug interaction, where it should be avoided. It shouldn't be combined with levodopa and also should not be used in concurrence with alcohol. And then as for safety, generally avoid it in pregnancy and also in lactating mothers. And then to wind up, I would say we've also been reminded just of the best clinical practice. Before you start any medication, do your baselines, do your BMIs, do your baseline lab investigations, and then you can now go ahead and have your patient benefit from the molecule. I would like, before we go to the Q&A, to welcome our sponsors, Redefine Healthcare, to just do a short presentation on the molecule as well and anything else they may have, and then we'll get to the Q&A and we'll call it an evening. Welcome, our team, Redefine.
This drug also cannot combine with it.
Which one is that one?
The Remeron.
What is the chemical name?
We use it. People are using Mitaz.
Okay.
Mirtazapine is dangerous because it also prolongs QT. So you can't combine it with this drug.
Thank you, Doc. Keep your questions in the Q&A. Dr. Witty is a well-renowned pharmacology teacher. Any questions you have, please put them there. I assure you he will tackle them for us after this presentation. Welcome, our team from Redefine. Mr. Patel.
Yeah, thank you. Thank you so much. My name is Pranay Patel. First of all, thank you so much, Dr. OVT, for giving us opportunity to at least showcase one of our product. When it comes to looking at Redefine Healthcare, I think I have a long journey with the neuropsychiatry segment because I landed in this country in 1997. Served Sun Pharma for 16 years, then another 5 years with Cipla, then Zydus, and then I started my own company.
You gave me my first one.
I have been blessed by Dr. OVT and all senior doctors who actually guided me how to, establish neuropsychiatry. And I have that pleasure of, sharing with you that, I've virtually worked on last 3 decades, almost all the molecules which are launched by those generic companies from India. Redefine Healthcare is our own company. My partner with, we are working together. Again, it is a rising of new era in healthcare. It's a Kenyan company. I have turned Kenyan. I'm a proud Kenyan. So when you are supporting Redefine, you are supporting Kenyan people. Be rest assured. I'm working with the same principle of bringing new missing molecules and trying to bring and make your work easier by having an extra options. So as Redefine, as a founder, we have over 2 decades of expertise in Kenya. We are focusing in a various specialty therapeutic segments with advanced option technology like implant, surgical, nutraceuticals, and very qualitative and a very unique pharmaceuticals. We procure our products from all the world, licensing body which are being used by manufacturers. So at least, and we allies with Pharmacy and Poisons Board Kenya. So to give you the best quality product. We have a principle of visions and mission with offering a high quality product with an affordable price and innovative technology. Because while serving those companies, I realized that still the pricing are still priced very high. While because of that mid-level companies coming in and their operational cost and all these things. So being a Kenyan, if I can import directly from the manufacturer, I can provide much lower price. And that you will witness as we move forward together as a partner. As a company, we have a value of integrity, excellence, innovations, and respect. And our future plans is that we want to become a preferred and a trusted resource for the country and for all of you, medical fraternity. We have our office in Westlands, and I operate from there, and my partner is also with me. I'll request Jafet, who is our manager, who will take over now, straight away to the product details. And the people who have joined late, I think this will turn out to be probably a recap of what was discussed, maybe in a more commercial way, but still the information are same. Thank you so much.
Thank you so much, Dr. Witty, and also Mr. Patel for taking us through Amisulpride and also the company Redefine. So very quickly, I'll talk about our brand. And here goes our brand. We present this product as a first of its kind, first time in Kenya, an atypical antipsychotic available in Europe since 1990. So redefine healthcare, as you've heard from Mr. Patel, we are providing hope, care for psychosis, psychotic patients, and we are presenting a gold standard formulation, which is Amired. So we've discussed, as Dr. Witte has talked about Amisulpride. As a company Redefine, we have Amired, 200 milligram, which again, it's Amisulpride documented, validated, effective in treating schizophrenia and also depression. So let's dig deep down on the mode of action very quickly. It has already been discussed, but I'll just mention a couple of things. It is an atypical antipsychotic. It is distinct from other drugs due to unique pharmacological profile. And it's also a selective antagonist of dopamine D2 and D3. So this one also, Dr. Witte has already discussed about it. It has no significant affinity for serotonin, alpha-adrenergic, histamine, or cholinergic, which you also saw in the previous slides that were shared. So this differentiates it from most other atypical, which often blocks both D2 and serotonin receptors. Its atypicality is partly explained by dose-dependent actions. So low doses is effective for negative symptoms of schizophrenia and depressive symptoms. So further, we explain the mechanism of action. So D2 receptors antagonist blocks dopamine D2 receptors found in various parts of the brain. They're involved in mood, reward cognition, and also motor function. And D3 receptors antagonists selectively block dopamine D3 receptors. These are primarily involved in brain's reward, emotion, and cognition pathways. We're just referring to the slides that you've seen earlier on. They are being investigated for treating neurological and psychiatric disorders like schizophrenia, particularly negative and cognitive symptoms. So very quickly, we look at Amired 200 milligram in schizophrenia. So augmentation has been considered a viable treatment option in clozapine-resistant cases of schizophrenia. It is an appropriate first-line treatment for the management of acute psychosis. So Amired works on dysthymia and the negative symptoms of schizophrenia by blocking autoreceptors D2 and D3. So this increased dopamine concentration acts on dopamine D1 receptors to relieve depressive symptoms in dysthymia and negative symptoms. Then we look at Amired 200 milligram in depression. So Amired 200 is approved and used at low doses in the treatment of dysthymia and major depressive disorders. Typical doses used in schizophrenia block postsynaptic dopamine D2, like receptors, and reduce dopaminergic neurotransmission. So these are also a few pointers that Dr. Witte has also mentioned in his previous slides. So Amired 200 is approved for treating depression, specifically in the European countries like Italy, Greece, and certain other countries in the European sector. So with the mechanism of action, this one was already explained, so I won't go through it. Permit me not to go through it. But just to mention on dosage and administration. So in acute psychotic episodes, the initial dosage is 400 milligram to 800 milligram. That means if we have Amired 200, that a patient can take 1 tablet twice or 2 tablets twice a day as an initial dosage. But in mixed positive and negative symptoms, it needs to be adjusted to obtain a positive response. Whereas in negative symptoms, where you'll require a little bit lower dosage, you'll give it 150 milligram to 300 milligram per day. One advantage with it is available as a scored tablet. So quickly, permit me to play this very brief video to understand it better.
So this is how our Amired looks like. It's a pack of 30s. It comes in 3 strips. So these are the 3 strips in the back. As you can see, our major indications are initiative dose. Initiate the dose is 200 milligram. Twice a day, you can give to reach 400 milligram. and maximum 200 milligram, 2 tablets twice a day to go up to 800 milligram, right? So this is the benefit Amirate 200 comfortably offers to you, having a 200 milligram, 200 milligram option. Now we also have a disposable aspect of this because we have a disposable tablet. Now being a disposable tablet, it allows your patients to take it with water, those who are fussy about taking the medicine while having, schizophrenia. At the same time, if you are looking at a lower dose like 300 milligram or less than that or 100 milligram, comfortably you can break this tablet because it has a code line, and this code lines allows your patients, your relatives to comfortably break it into half and put it in the water. Why? Because it is a disposable tablet. So since you put it in the water, within few seconds, once you stir it, it immediately dissolves that. So your patient can comfortably take it. And this benefit is being offered at just 80 cents of 200 milligram. Thank you so much.
Thank you so much. It's a brief video that shows our Amirate 200 milligram dispersibility aspect and also the dosaging aspect of 200 milligram twice a day or 2 tablets twice a day. So the primary action of Amisulpride depends on the dosage administered. Low doses, that is 50 to 300 milligram per day. And here you'll remember that 300 milligram because our tablet is code, so the patient can take 1 tablet and a half. So it's suitable for treating negative symptoms of schizophrenia. And it is antidepressant properties in conditions like dysthymia. While high doses, 400 to almost 1,200 milligram per day, suitable for treating positive symptoms of schizophrenia. One thing that we really need to also understand is the caution to be taken at bedtime to avoid feeling sleepy during the day, and also use cautious while driving or doing anything that requires concentration, as Amisulpride can cause dizziness. This also, we saw it in the previous slide that Dr. was talking about. So also alcohol, driving, that we've already discussed. And here are the documentations and a couple of references that our slides also are based on. And also you can decide to take a couple of the research papers and see more about our Amisulpride, which is Amirate 200. So with that, permit me, the moderator, to also mention other unique products from Redefined Healthcare. Just a mention, we have Boto 10, that is vortioxetine 10 milligram. Yes, a serotonin modulator and stimulator molecule. It has multimodal mechanism of action towards the serotonin neurotransmitter. It simultaneously modulates one or more serotonin receptors and inhibits the reuptake of serotonin. Also works by increasing the amount of serotonin in the brain that helps them maintain the balance. So in summary, about Voto 10, as much as it is a serotonin reuptake inhibitor, it acts multimodally in different receptors like 5-HT1A, 5-HT1B, also antagonizes 5-HT1D, antagonizes 5-HT3, and also 5-HT7. So all these helps in reducing depression. Lastly is our Risem, that is 200 and 400 milligram. Risem is S-adenosyl L-methionine. So Risem, actually, as we grow old, it depletes in our bodies, and we need to have a sense of also topping it up because it helps in the production of neurotransmitters like dopamine, serotonin, and norepinephrine. So in depression, it also helps so much reducing depression. Also Alzheimer's disease, and patients who suffer from brain traumatic injuries. Also, the SAMI levels reduces. So there is the need to top up the SAMI levels. So we'll require another CMA. I'll talk to maybe Dr. Rajab to give us another session that we'll have a talk about one of the brands like Voto or Risem. So thank you so much, Dr. Rajab. It was as brief as that.
Thank you, Javed and Patel, for that brief but very elaborate presentation on the molecules and the brand placement as the sponsor for this evening. So colleagues, there we have Amisulpride, Amirate 200, and we will provide this information in check the KPA YouTube channel in a few days. This presentation will be there, so that in case we've missed anything on your end, you will be able to go through the whole presentation at your own pace and ensure that nothing passes you as you endeavor to pass the benefits to the patients. I will quickly go through the comment section. Dr. Witty, kindly get back to the steering chair. So there is one from Dr. Raymond. Here is thank you so much for the nice presentation, Dr. Witty. Dr. Sylvia, is prolactinemia dose dependent? And if so, how do you manage it?
Low dose. Prolactinemia is a problem with just the newer drugs, but it is less on amisulpride, though it is exactly there. Now, how do you manage prolactinemia? You don't stop giving medication, and again, it depends on the degree of the milk coming out or whatever. And most of my patients that I've seen with most drugs like this one, which cause invagus astena, and that drug, they tend to have the same pattern of behavior. And prolactinemia is not a big deal unless it is a patient who put a lot of attention to it, that may make the therapy go wrong. Once the therapy is matured, the prolactinemia, they disappear.
Maybe as a follow-up, Doc, we've seen with these guidelines that say sometimes if you add a small dose of aripiprazole, it can help with the prolactinemia. I don't know if in amisulpride is the same case.
Same case.
Okay. Another question here from Dr. Raymond again. One of the challenges in prescribing medication is the socioeconomic factor. I would like to know the cost of this medication compared to other antipsychotics. I think that has been answered, 80 shillings per tablet. I think that was effectively answered. Dr. Tugem from Cameroon, happy to see you too. Thank you for joining.
Nice. He links.
Yes, Doc.
Tell him to get in touch with me.
Okay. Dr. Kingi, awesome presentation by Dr. Witty, our teacher. What is the cost and which pharmacies have it? Attractive efficacy and less weight is a plus. So basically, Dr. Kingi is saying the efficacy being attractive and also having less weight problems or just metabolic syndromes is an attractive reason to consider this medication. I think the question on cost has been answered. Maybe availability around the country is the question to be answered, maybe by Japheth.
Yeah, definitely. Dr. Raja, about availability, we've put it in most of the leading distributors in the country, like Transchem, Nila, Omira. Also, we've gone to the hospitals like Madare. Now they have it. They've already given an order. Chiromolene, they already have it. We are looking forward to putting it in Aga Khan. If any doctor will help us in that, we really appreciate. Also, Mpisha Hospital, also they are going to stock it very soon. So we are in the field ensuring that it is available in each and every corner of the country.
Yeah, please
we'll share the contacts of the company and also our contacts in case your patient requires it. We are also available maybe to reach out to the patient or to the doctor to give the patient, or to the pharmacy to give out to the patient. Thank you.
Yeah, please don't forget Kenyatta National Hospital. I have vested interest.
Yes, tomorrow morning I'm there.
Thank you. Dr. Shalin Kumbo is asking, amisulpride remains underutilized in this context. Could you walk us through where you see the gap coming from? That is the first question. Where is the gap in the utilization of amisulpride?
I'll talk.
The second one, how would you characterize its side effect profile relative to other second generation agents, particularly with regards to metabolic risk, prolactin elevation, and extrapyramidal effects to inform clinical decision making in selection.
Yeah. Now, what is the commonest way of prescribing in Kenya? Most people, when they diagnose their cases as bipolar, and then they are attracted to things like quetiapine and etc. Now, in the mind of me, I feel that the bottom line of all mental illnesses is psychosis. But that does not mean there would be no, but if you talk of depression, there is no word depression in your language, all African languages. So it is a foreign name to us, just like democracy is a foreign name. But still, people get depressed. People can get, we know from what we have been taught, people get depressed. But this medicine, Amired tend to cover both the angle of depression to the angle of psychosis, and without fear of either overdosing, because I have been telling them that my prescription habits with Amired or Amisulpride before has been not more than 400 milligrams per day. Most of the times I give 200, 100 milligrams BD, and patients that have done well for it for a long time and never switched to other antipsychotic drugs. But my observation so far in terms of drugs that are being in Kenya now, we are running short of medicines that can deal with acute psychosis when it's in danger point, where you need to sedate somebody. The number 4 drug in the list of antipsychotics is flupentixol. The flupentixol, the acute Acufase, clopixol Acufase, is the one we have in Kenya is dead as a dodo. You give it to a patient and tomorrow the patient is walking. Whereas the one that we were getting from Denmark, you would give it to a patient and for 3 days the patient is sleeping. Now we lost that. I'm going to observe the performance of Amired closely with what the Solians and other things were doing. And I do trust that this one would work.
So the second question was about, let me just go back to it. How would you characterize its side effect profile relative to the other second generation, especially as regards metabolic risk, prolactin elevation, and extrapyramidal side effects?
You'd say it very low compared to the others. Compared to the others, you classify as effective. And again, compared to clozapine has got blood dyscrasia effect. This one hasn't.
I think even for extrapyramidal side effects specifically, I think maybe to add on, we said just because it actually
cures.
Yes. Okay. The next question: What is the safety profile in the younger population, 18 years and younger? Dr. Mary Njuguna is asking that one.
Now, you don't go beyond with the younger generation. Depending on the ages, who can get a psychosis. If it's a middle age, early teenage, they would still go for almost normal adult prescription, depending on the degree of the illness. But if it's a very young kid, then you would go between the 50 doses, 50 milligrams They're 100 milligrams, and you would give around 150 per day.
Okay. I think there's another question by one Ojeng here, I think about prolactin, which we have covered. Another one, as a person who got better after suffering from major depressive disorder, I recognize that as a patient, you might decide to depend on the drug instead of actually getting better. My question is how, in quotes, addictive is Amired 200? And what therapeutic techniques could you employ in order to make sure that patients aren't hooked to the drug?
No, I don't think there is anywhere recorded that Amirate can dependency drug creating. No, they don't. You can stop it today and you won't get any withdrawal effects.
Okay. Dr.
The withdrawal effect that may come is that the illness will come back.
Thank you. Dr. Siengo is asking that she missed part of your presentation. She would kindly request that you recap the comparison between Amisulpride and clozapine, and also the use of 50 milligrams. I think we said the lower doses are good for negative symptoms. Maybe, but she is requesting a comparison between Amisulpride and clozapine and use of 50 milligrams of Amisulpride on negative symptoms of schizophrenia.
Clozapine is the king of drugs. Unfortunately, it has its own negative side effects and we've not monitored. Now, amisulpride is not a drug that you require to monitor daily like you would in clozapine. Amisulpride, the efficacy of amisulpride is rated nearly as high as that of clozapine. Is number 2 actually in the list. But the negative profiles of clozapine, however it's good as this, amisulpride beats it.
Okay. Dr. Eva Musheru is asking, thank you, Dr. Witty, for the insightful presentation. Please clarify the advantage of Amired being dispersible.
The advantage of Amired being dispersible.
Yes.
Yeah. Some of our patients are begged to take medicine, and there are times when you find families have a big difficulty in making a patient get to accept medication. There are some families where you find that they can whisper to you that we give him medicine, but he doesn't know, meaning they put in his food, and that's why it's a little bit normal, but he doesn't know that we do that. So the good thing with Amired, it is absorbable, it is dispersible, and it has got no negative taste when you put it in food. Just like we used to have Clopixol drops. Clopixol drops was excellent. You put it in drinks or in food and nobody will taste it. Amired, you put it in food, if I have dispersed, there will be no problem. The patient smells or tastes anything. So
thank you.
It's good.
Okay. I will combine questions, one from Dr. Victoria Uche and then another one from Dr. Wairoto. Thank you, Dr. for the insightful presentation. In your experience, is amisulpride superior to risperidone?
Yeah, it is. Risperidone is number 4 in the list.
Whose list is this?
The list, I got a list from somebody in Italy, where in France, actually, the makers of this amisulpride.
Yes.
But I do know that you know that clozapine is the king of antipsychotics. Did you know that?
Yes, Doc.
is the best medicine to help someone who is very suicidal, and we have seen documented on patients who have done that. Amisulpride, I can say, is an excellent medicine to deal with severe extrapyramidal reaction. It calms it down, and without even using a kineton. Now, the amisulpride generally is associated with less weight gain, less sexual dysfunction, and better management of depressive symptoms, while both have similar lower rates of extrapyramidal reactions. Efficacy: both drugs show similar efficacy in treating positive and negative symptoms of schizophrenia. Weight gain: risperidone is associated with a significantly higher risk of weight gain compared to amisulpride. That is correct. Depression management: amisulpride is more effective in treating comorbid depression in patients with stable schizophrenia. Side effects: amisulpride causes fewer endocrine and sexual side effects compared to the risperidone group. Patient ratings: based on user experiences, amisulpride often receives higher ratings for its overall effect.
Okay, thank you. I think that answers Dr. Wairoto's question, where it was excellent presentation. Dr. Witi, our teacher, please comment on how to mitigate weight gain from amisulpride. So this question kind of assumes it causes some weight gain. So how do you mitigate it, or does it not cause weight gain?
This one does not cause weight gain.
Okay. Dr. Siango asks again, please, manufacturer to classify if it is scored, and also how, and also low dose on negative symptoms. I think this was clarified, Doc. It is a 200 tablet that is scored. You can break it into 100 milligram. So far, that is what is available. The 200 milligram is scored.
Correct.
Okay. There's 4 more questions, I think, from anonymous attendee. Can one use amisulpride for negative symptoms and another molecule for positive symptoms? Basically, combine 2 antipsychotics.
Why? It does both. It does both. It takes care of negative symptoms. It takes care of positive symptoms.
Thank you. Another anonymous attendee, well done. Please comment on effect of low dose of amisulpride on negative symptoms of schizophrenia. I think this one we've asked. Dr. Naima, sorry.
Okay.
Why does low dose improve negative symptoms while high dose improve positive symptoms?
You refer you back to the pathway through the synaptic cleft in handling the D2 and D1 receptors, D2 and D3 receptors.
Yes.
The answer you'll get there.
Thank you. I think that is it. It has been an interesting conversation. The Q&A has been lively. I think just from questions, it means there was a lot of interest. There was need for this conversation on this kind of molecules. I have always shown respect to redefine for daring to dream, introducing molecules that not many other farmers are daring to chart that path. I think we are in good time. The questions are done. The attendance has been encouraging. I'm wondering whether we should be doing this on a Tuesday or it's just one of those days things aligned. But I would like to take this opportunity to thank you, the attendees, for showing up in large numbers, over 107. That's a good way to start the year. I thank you, Dr. Witi, for taking your time and coming out of retirement to hold up.
It tells you clearly. Me, I can't attend the Thursday meetings for my personal reasons.
I totally get it.
Yeah.
Yeah.
But Any other day, I'm okay. Tuesday,
Sure.
Monday, Saturday, Tuesday, Wednesday, Thursday, Friday, not Thursday,
No.
not Thursday, not Thursday.
I thank our sponsors, Redefine Healthcare, for taking time to also allow us to have this conversation with you as the sponsors for the day. I would like to encourage us to pass this knowledge to colleagues who, for one reason or another, did not manage to make it here, and pass the benefits of these molecules to our patients when we do our day-to-day work. As how do you access this information? This video, this session has been recorded. This video will be uploaded to the KPA YouTube channel in a few days. So be on the lookout, and you will be able to access this webinar and go through it at your own pace. I would really like to thank you all for taking your time. I appreciate, and have a lovely evening. God bless.
Dr. Rajab, sorry.
Yes.
I've just been informed that we are providing samples for everyone who has attended, especially the
Okay.
doctors. So
Okay.
we'll make a follow-up. Yeah. If we get the list, it will be okay. So that we give all samples.
Oh.
Yes.
To try it out in future.
To try it if you. So we have a
Yes.
room for that.
Okay, the attendance list will be provided eventually by the IT team, so that is okay. And then you can be able to out and reach their colleagues wherever they are.
It's a good offer. That's why this guy is kind.
CPD points are automatically uploaded. I see a question there. So long as you signed in with your email address, the one registered to your KMPDC portal, the CPD points will automatically be uploaded to your portal in a few days as well.
Dr.
Thank
Rajab.
you. Yes.
This is Patel. You know, we were talking. So Dr. OVT said that why 3? Why not 20? Please look into this next time.
I don't follow. The CPD.
CPD.
Oh, well,
3. Why not?
Why not 20 for the retiree?
No, for the presenter, usually it's 5. And then for the attendees, it's 3.
You have to charge even teachers in medical school.
Well, we'll talk to the board about that, Doc.
Like Wairoto and myself.
Yeah. Anyway, good conversation. Thank you so much for attending. Thank you, Dr. Witty, for making time. We appreciate. Thank you to Redefine Healthcare for being our sponsors. Have a lovely evening to all.
Thank you.
Thank you so much. Thank you so much.